On the Go podcast.
Future Tales of Achilles, the Regenerative Approach, live at ESCA 2024 in Milan with Jon Karlsson, Professor Emeritus of Orthopaedics and Sports Traumatology at the Sahlgrenska Academy, Gothenburg University, and longtime Editor-in-Chief of KSSTA, having a coffee break with Dr. Jari Dahmen, Amsterdam University Medical Centers, University of Amsterdam. My name is Taka Oshima, and this is On the Go, the podcast all around orthoregeneration.
So we're here for the On the Go podcast with Professor Jon Karlsson. I've known you for quite some years now. We worked together a lot at the KSSTA Journal. And we start our podcast always with the question, how do you drink your coffee?
So Jari, just before I answer to that, the pleasure is all mine to be here with you. And thank you for our great collaboration through the years. And good luck with your future work.
Thank you. Thank you.
How I drink my coffee? Yeah. I like to drink my coffee on the run because I am often very busy. So I take a cup of American coffee and 1/3 milk, and then I go. But when I relax, I like cappuccino.
Cappuccino. So you make a cappuccino at home when you relax?
Yeah, can do that.
And you take it on the car with you to the hospital?
No, I don't. In the hospital, I maybe go and see a patient.
Yeah.
And prepare for surgery, and then I just relax for a while and take a cup of coffee.
In between the cases?
Yes, I do.
And do you have one specific spot, maybe around your house or in the hospital?
No, not really. I'm more on the run.
I'm on the run.
Yeah.
Okay. So it's on the go, on the run for Jon. So that's good to hear. Then we shift towards the main topic of today. That's Achilles tendon ruptures and tendinopathy. You just had your Einar Eriksson lecture that you gave. We want to shift towards the future with this podcast. So we have a vision of 2040. But before that, we want to know where are we now with Achilles tendinopathy and Achilles tendon ruptures.
So you want me to look ahead 15 years. I think that's difficult. If you look back, at my career, when I started working with Achilles tendon problems, then you have two types of problems. We have total ruptures, and we have Achilles tendinopathy or chronic pain. If you look at the ruptures, it was inevitable that all of them should be operated on, and sometimes with large surgery. This changed, and it mostly changed because of a large Swedish randomized control study where it was shown that it was possible to treat Achilles tendon ruptures non-surgically. Mm-hmm. It was not that they were much better non-surgically treated, but the complications after surgical treatment were numerous. So that was the real difference. This is different today. The complications are few due to the mini-invasive surgery. And you can also do it percutaneously, meaning that you will have almost no risk of surgical infection, for instance. So this has all changed. But we know that Achilles tendon ruptures can be treated without surgery and with good success. And many of them who are treated non-surgically with good rehab program. And good rehab program means early range of motion, weight bearing, etc. They are good. However, the rate of re-rupture is higher than after surgical treatment. Yeah. So after surgical treatment, the rate of re-rupture is almost 0%, and you cannot get better. The rate of re-rupture after non-surgical treatment is somewhere around 10 to 15%. Yeah. But that would mean that you have 85 to 90% good. Yeah. And that would be considered a good result in many or most surgical treatment protocols. Yeah. So that's not so bad. So what should we do
For the
today?
future.
What should we do for the future? It's very difficult to say. I think that we still have one problem that we have not solved, either with non-surgical treatment. We see this problem more often with non-surgical treatment than with surgical treatment. But we have not solved it with surgical treatment yet, and that's tendon lengthening. And tendon lengthening means that you lose power in your calf and that your return to activity is not as good as it should have been.
Mm-hmm.
So if we can solve this problem with tendon lengthening and make sure that we have no tendon lengthening, we probably have solved the problem of acute total tendon, Achilles tendon ruptures, I would say.
Yeah.
But this is really an unsolved problem. And this is something that researchers in my group, for instance, because we have a very good research group doing this work on Achilles tendon research, and other groups are looking into. And I would like to mention the names of Michael Carmont, Katarina Nilsson Helander, who are doing very good work on this. But we have still not solved it. So we are still there. And it's unpredictable who will have elongated Achilles tendon.
And who will not have it.
And who will not.
Yeah.
And I don't know. I cannot see in future how we will reduce the risk. Yeah. But we need to continue to work on the problem. If we look at a measurement that we have done called the ATRA, A-T-R-A, ATRA angle, and that's the resting angle after a rupture compared to the other side. And when we operate, we try to make the ATRA angles the same. Yeah. Possibly, we could exaggerate this and make the Achilles tendon stiffer and reduce the ATRA angle even more than to normal. But we don't know how much today, and this has not been done in a big study yet.
So
another thing is what I can see is that if you look at the anatomy of the Achilles tendon and the Achilles tendon complex, the gastrosoleus Achilles tendon complex, and there are three bundles, and probably we only operate on two of them when we operate today, the two superficial. And if we operate on all of them, including the deep bundle, we probably might be able to reduce the risk of tendon lengthening. And this is a study we are going to undertake in my group, and we have a PhD student who will work on this, and we will work on this in multi-national collaboration with a group in Denmark with Christopher Barfoot and his group. Okay.
And so if you would have been given, for example, 20 million euros to conduct a study in order to find out who is prone to re-rupture in the conservative group and who is not, what would you do for the next years?
We already know that they don't re-rupture.
Yeah.
If we use the technique that one of my PhD students, Niklas Olsson, showed in his thesis, we have 0% re-rupture. So the risk of re-rupture is almost zero. And that's actually the only study with 0% re-rupture. So it was a randomized control study. But there have been other studies showing very low numbers of re-rupture. So re-rupture is really not the problem. So if I would be giving a lot of money to do research, I would probably try to create a new surgical technique where I would reconstruct all three bundles, even the deep bundle, in order to reduce the risk of tendon lengthening. Yeah. So that's what I see in the future for the next few years. Yeah. But looking 15 years ahead, I don't know. It's very difficult.
No. And for the conservative group, what kind of research would you do, or how would you want to prevent events that are not wishable?
I think for the conservative group, we have actually come as far as we can because we have improved the rehab protocols.
Yeah.
And they are not treated conservatively with 8 weeks, we say if you go back in history, 12 weeks in plaster, 8 weeks in plaster, 4 weeks in plaster, and 4 weeks in brace, and now maybe 2 weeks in plaster and 5 or 6 weeks in brace. So this has been evolution going on. So that's good. But I think that we are more or less as far as we can. I cannot see much improvements in the conservative group, really. Conservatively treated Achilles tendon rupture that heals. Function is very good. So I think that we are fairly much at the end there. If you think about things like injections or PRP or something like that, I don't know if it's helpful. Time will show. Studies will probably be done, but I don't know.
You don't know.
It's very difficult.
Yeah, it's difficult.
If you look back, Jari, on the tendinopathies. So when I started doing surgery more than 40 years ago, we did a lot of surgery on tendinopathies. We opened wide, we opened the paratenon, we opened the tendon, we looked for a part of the tendon that was looked more degenerative, and we removed this part. And then we put it back together and plaster cast for 4 weeks, 6 weeks, something like that. Then we reduced the plaster cast, and at the end we removed the plaster all the way. No more plaster, range of motion. But then the physiotherapists came with their studies, and the studies were on eccentric training, eccentric concentric training. It doesn't matter, both are good. It doesn't really matter. I think it's very difficult to do only eccentric training. So probably you do eccentric concentric training all the way, but just to train the tendon with pain and do it and go on even if you have pain, and go on maybe 2 weeks, 4 weeks, 3 months, and then about approximately 90% of those with tendinopathy in the tendon proper, they will be functionally well recovered. I don't know how the tendon looks because we don't have studies with MRI or ultrasonography in the long run on these patients, but this is what happened. And this is a very interesting evolution because 20, 30, 40 years ago, surgeons were doing all of this. Now, surgeons are doing nothing at all, almost nothing at all. Very few patients with chronic tendinopathy, chronic tenders, a painful nodule in the tendon who need surgery. Then we should think about one thing. If we have chronic Achilles pain, then we might divide it into two things anatomically. In the tendon, and the physios will take care of it. Will be fine. In the insertion, and there we often have Haglund, bony osteophytes, sometimes some bone pieces inside the tendon. The physios do not take care of this. They have, okay, maybe you send them to a physio, but and maybe some of them are good just because time will heal. But by and large, they need surgery if they have problems. And the surgery may be based on removing the bone, repairing the distal tendon, removing the bursa, maybe reinsertion of the tendon. And sometimes it's major surgery. And I've done this many times. And we need really to distinguish because these are two different entities, the tendon and the insertion.
And so for the future, in that sense, for the tendinopathy, you don't think the protocol will change that much? Is that right? Or how do you think it will change in some 20 years?
I guess that protocols will be even better. And I've seen protocols rapidly become better. The rehab protocols have become better. I worked very close with very good physios, like Karin Silbernagel, Anneli Brorsson, and who are very, very good on this. And they have put forward the protocols. The protocols are better, and we know better how to dosage and how much power we should give, etc., etc. But those are minor things. So maybe any major, any injections, any PRP, I don't know. Okay. I don't see it at this moment, but I'm sure that there will be researchers who will test.
And you still think there is a place for surgery for Achilles tendinopathy in 2040, 2050?
Again, it's very difficult to look 15 years ahead. So in the next years to come, I would say, if you have a little bit shorter, I would say that it's about the same as today, because in surgeon, yes, there's definitely a place for surgery and rehab afterwards. In the tendon, very little place for surgery, maybe less than 10%, maybe even less than 5%. So that's what I say. Maybe we can see that we can refine the rehab protocol so much that there will be no place for surgery in Achilles tendinopathy in the tendon itself. But I don't see, I cannot see that we will be going the same way when it comes to the insertion. I think there will be a question of surgery in those patients who have pain, in those patients who are symptomatic.
And so maybe the same question here, because you've done a lot of research on tendinopathy as well, mid-portion and insertional. Now, if you have a research group of 20 people studying this, and you would again be given a lot of million euros to do some research, what kind of questions would you like to see resolved?
Yeah, if it would give me a lot of money and I have a group of 20 people, I'm the boss and I can tell you, you do this, you do that. That's a very nice position. Yes, I love it. So then I think that we would think about adding some kind of injection, some PRP, and see if we can eliminate surgery altogether. And I think that I would be thinking about a randomized control study with a good protocol and a good protocol plus PRP and compare. If we go to the distal insertion problem, I would guess that a randomized study between arthroscopic treatment and open treatment would be nice.
So that's maybe something that you will still do on the side for the next years.
What I will do? I will go out with the dog.
Okay. also good for regeneration for yourself.
No, you get cut. No, I'm still doing this surgery, but what kind of surgery I'm doing? I'm doing the surgery of the distal Achilles tendon. And I've done many, and I still do them. And what surprises me sometimes is that people tell these people to go to the physiotherapist, and they are not any better. Go to the physiotherapist again for 3 months more, and they are not any better. So I think that we should understand when we should operate. We should operate early, when we should not operate, and when we should try physiotherapy or conservative treatment, and when we are confident that conservative treatment, the physiotherapy will make the trick, will make it all the way. So I think that we should be confident to know, yes, we should do the surgery. We should not wait. We should not go for physiotherapy for 6 months because it will not help. We should be confident to understand and tell patients this. And we should be confident on the other end of the scale, a physiotherapy will help here. And if you're not good after 10 weeks, maybe do 1 more month and you will be better, etc. And there's one thing that I often use in my pedagogical thinking with patients to look at the curve, what I call it, your symptoms versus time. And if your symptoms are slowly on the way down, you should not do surgery. Yeah. You should let your body take care of the healing.
Yeah, that's something that we're going to consider to also teach to others, I think, and to keep in mind. Then we've talked a lot about Achilles, tendinopathy, and ruptures. So I think we know much more about that now. So now I want to shift a little bit to the KSSTA, because obviously the On Foundation has a lot to do with regeneration.
Not the coffee.
On the coffee.
Not the coffee.
A lot of papers on regenerative orthopedics are being published in the KSSTA Journal. What is it like for you to have been leading that journal for the past loads of years?
I've been the leading editor for 16 years. It's been a lot of work. It's been very interesting. I've learned to know a lot of good people. I have seen many good papers. I've also seen many bad papers. As I said this morning, I rejected more than 15,000 papers.
Yeah.
But if you do it properly, if you explain to people and you're not rude, it works. I have very few complaints about my work and about rejecting papers and explaining to authors how to do this. Have I seen anything change through the years? Yes, I've seen better papers. I see better research methods. Yeah. And this is something that we have done a lot of work in the journal. You have done it too, Jari. You have been involved in publishing the research methods papers that we put together in a small book now. And we see better methods. We see larger cohorts. We see better statistics, sample size calculations. We literally have no papers that don't have proper IRB approvals, etc. And this has happened through the years. Yeah. So there's a shift in publications like this. Yeah. I talked to Bruce Ryder this morning, and he agreed with me that this is, and he's the editor of American Journal of Sports Medicine, which is a very good journal from America, a little bit senior for KSSTA.
Yeah.
So, but I think that we need to look to the future. We need to look for what's happening on the publications area. We need to see what happens, for instance, how we can use artificial intelligence. And we had this short discussion about this with the journal editors yesterday. Yeah. That artificial intelligence cannot be a reviewer, cannot be an author. It can only be a tool that we can use to help us to make papers better, like large language models, maybe illustrations, etc. Yeah. And I've seen the pedagogical value increase and improve through the years, absolutely.
And so with regards to publishing your paper in KSSTA or any other journal, what is your top 3 of the tips that you would give an author in the orthoregeneration world to have a successful paper publishing? What is necessary to get there?
First of all, you must have a good research idea, something that is new or fairly new, or also, and then you need to prepare well when you do the research. You need to think about things like IRB approval and sample size calculation. All this needs to be in place. You need to think about what type of a study. Is the clinical study? It's more difficult to follow patients and find where they are, and some of them don't want to return to follow up, etc. Or is it an animal study? Because in most cases you need fewer animals, and it's more it is more standardized, so to speak. And when you start to write, follow the simple rules. Do it well. Read the instructions to authors, and do a good paper. Yeah. Short introduction, good methods, short results. Discuss what you found. Draw conclusions from your own findings, etc. Yeah. So this is easy, but also many authors, they don't do this. They don't read instructions to authors properly.
Yeah.
And they should do.
Yeah. So we also had a podcast with Professor Lisa Fortier, who you also know, and
I know her.
She gave a very good tip, and I would love to hear from you what you think of it. She said that it's a good tip to write the editor a personalized letter stating why you think the research is well done, and actually asking the editor what he thinks of it personally to see if you can improve it or that you have to wait a little bit more. What do you think about this?
This is good. This is good.
More of a conversation.
I get a few letters like this from authors, and they ask me whether this or that is of interest, whether it would fit into the journal. Of course, I cannot promise them that I will publish their paper, because in most cases they just show me a short abstract or something, or an idea. Yeah. But then I can honestly tell them that this is something that will fit into the journal, and that the work they are doing is of interest. Yeah. And I always communicate, I always answer them. Maybe it goes into 2 or 3 emails or whatever, but it's well worth it.
Yeah. Do you think it's a good one to do?
Yes, it's a good idea. Yeah. And I would be very disappointed in an editor who would not respond well to a request like this. I think it's a very, very reasonable request.
Yeah. So that's maybe a good one to also do in the future, to ask some different editors what they think of the manuscript or some abstract before you fully describe it to a journal.
Absolutely. And also think about what type of journal is this? Is the journal you targeted is the correct journal for this? Do you have papers already on similar topics that have been published? It may be a mixed blessing if everything is already written. And you should also, as a young author, think about very few things are entirely new. So you need to find new angles, etc. But communication is very good. And I would say that I would be very, very disappointed in an editor who would not answer this well. And I always do.
Yeah, that's good to hear. Then we're gonna slowly go to the ending of the podcast, and we always ask our guests some unexpected questions. So Jon, what is something that most people don't know about you?
This is a very difficult question. I really don't know.
Maybe
something from my. People, they know, most people who have any kind of interest in me, they know that I come from Iceland. They know that I was born and raised on a farm, and they know that I played basketball when I was younger. But maybe they don't know that I had a dog when I was a kid. And this dog, he became 12 years old before he died. So maybe
that.
Yeah. And so now when I retire from the journal, I probably have a dog again.
The same race of dog, or or different.
Why not? Icelandic dog.
Yeah, Icelandic dog. That's good to hear, and hopefully you will have many nice walks with your future dog again. That's what we
Thank you, Jari.
At least.
Good to work with you. Friendship.
One last question. Who are some 3 people that you still want to have coffee with in your life? Either they could either be dead or alive. Some inspiring persons that you still want to meet.
Barack Obama.
Yeah. And 2 more people.
2 more.
Yeah. Mm-hmm. Barack Obama. Maybe some people you want to still meet from the past.
I don't know, but I think that I share his values, and I think that it would be very interesting.
Okay.
I could name Bill Clinton as well, because I also shared his political values.
Yeah. So Barack and Bill.
Yeah.
That's a good way to end. And Jon, thank you very much for being on the podcast as a guest, and we appreciate it a lot.
Thank you. I appreciate our friendship.
Thank you.
This was On The Go, the podcast on orthoregeneration. For more content, stay tuned at my.on-foundation.org. Thanks for listening, and have a great day.